My name is David Kooby. I'm a surgical oncologist at Emory University School of Medicine. I specialize in complex gastrointestinal surgery and focus on upper gastrointestinal tract. I'm full professor of surgery. I am the vice chief of staff at the Emory St. Joseph's location and the surgical lead for the northern arc in the Emory system. So gastric adenocarcinoma is not a terribly common cancer in the United States, the rate of which has dropped with the advent of refrigeration and no longer having to salt and cure our meats. So we aren't exposed to as many nitrates, but yet we still see it. Localized gastric cancer, so about half the cases will be localized at presentation. And then we have to decide which way to approach it and what type of surgery to do and how to time surgery with other therapies such as chemotherapy plus or minus radiotherapy. So when I meet a patient with gastric cancer, number one, I've got to see that they're in good enough shape for any type of surgery. So I've got to look at their level of fitness. Number two, we've got to define where the tumor is. And that's a key thing. You may get a biopsy on a piece of paper that says gastric adenocarcinoma. But if the tumor is down by the pylorus, that's a radically different deal from if the tumor is up by the GE junction. So localization of the tumor is imperative. Second, you have to determine the staging of the tumor. How thick is the tumor? Has it invaded the wall of the stomach, T1, T2, or T3? Certainly a T4 tumor would be a different level of involvement. And then you've got to determine if lymph nodes are involved. And gastric cancer has the unusual ability to spread through the gastric wall into the peritoneal cavity, and you have to determine if there's peritoneal involvement. All of that will impact the decision to operate, not only whether you do a total gastrectomy, a partial gastrectomy, a limited resection, or other. And so the next thing we usually will do is a staging procedure with a diagnostic laparoscopy, with an upper endoscopy to confirm the location of the tumor. And if it appears appropriate, based on staging, put a portacath in so that patient potentially could get preoperative chemotherapy. And then you determine what operation to do. So some of this has been worked out by some studies that have been done in the past, looking at doing a total gastrectomy for every patient, regardless of the location of the tumor, versus doing a lesser operation when possible. And the reality is doing more is not always better. So a total gastrectomy for distal gastric cancer is almost certainly excessive with poorer outcome and higher patient dissatisfaction. So in the circumstance that the tumor is confined to the lower half of the stomach, typically we get away with something called a distal subtotal gastrectomy, where we remove the lower 2/3 of the stomach, the surrounding lymph nodes, typically do an extended lymph node dissection, better known as a D2 lymphadenectomy, and then have the patient recover from that. If the tumor, however, is closer to the GE junction, then you have to decide whether a total gastrectomy is appropriate, or whether you're actually going to have to do an esophagectomy and typically I would get my thoracic colleagues involved for that, where I would mobilize the stomach, they would mobilize the esophagus, pull the stomach up into the chest, remove the lower 2/3 of the stomach with the upper 25% or so of the stomach, remove the lower 2/3 of the esophagus with the upper 25% of the stomach, and then do a connection in the chest or anastomosis in the chest. So location matters, extent of tumor matters, and again, obviously patient fitness matters. The next thing is, what about a very early tumor? What if we find an in situ gastric cancer or even a T1 gastric cancer with good features? In that circumstance, depending upon the experience of your gastroenterology colleagues, you may be able to get away with an endoscopic mucosal or endoscopic submucosal dissection, in which case you could obviate the need for formal gastric resection altogether. So the most appropriate approach to gastric cancer will require adequate staging and adequate localization in order to know which category the patient should fall within.